So I'm very happy to introduce Dr. Julie Sosa, who is a surgeon, and then Dr. Emerson, who is the former editor of the journal Thyroid, the official journal of the American Thyroid Association. The purpose of the session is to give us examples of observations that we can make in the clinic, and then take those observations, think about them, turn them into case reports, clinical projects, and in some cases, careers that begin from observations in the clinic. So we want you to be aware, to be focused and attentive in clinic, because that's where pretty much everything begins and ends, and ultimately we want to always take things back to the bedside, no matter what we do in the research field. And then Dr. Sosa will give us an example from her own clinical and research career, and then Dr. Emerson will follow up with guidelines on how to begin to think about taking some observation or case and begin to thinking about writing it up and the process of trying to publish something. All right, so without further ado, I will turn it over to Dr. Sosa.
So thank you very much. It's a real privilege to speak to you all today. And the only disclosure I always make among a predominantly populated group of endocrinologists is that I'm a surgeon. So that's my only disclosure. I think when a lot of people talk about translational research, they talk about, bringing science from the bench to the bedside. But I think at heart most of us are clinicians, and in fact translational medicine and translational research actually starts at the bedside with patients who we care for. And the example I'm going to give you today is of how we started with a patient and a problem that the patient had, and couldn't really resolve in our own minds what the appropriate treatment strategy would be. We then took that question to the bench and performed a clinical trial to elucidate an answer that remarkably in the end was incorporated into practice guidelines. Not American Thyroid Association guidelines, but NIH workshop guidelines that hopefully will translate and affect patient care at a population level rather than just one patient who sat in a clinic chair one day. So we start with the case of a 65-year-old woman with primary hyperparathyroidism. So I apologize, this is not thyroid-based, but parathyroid-based, who was found on routine serum screening to have a problem everyone I'm sure in this room has seen hundreds of times. So with a moderately elevated serum calcium to 10.4, with top normal on our assay being 10.2, an elevated intact PTH of 110 picograms per mil, with top normal on our assay being 69. She had normal creatinine and a normal bone mineral density. She had, however, significant complaints, and her complaints were those of fatigue, myalgias, forgetfulness, and difficulty concentrating, and she used what we not infrequently hear, and that is the catchphrase, "I feel like I'm in a fog." So this was an educated patient. She'd been on the internet, and she had read that these were all symptoms that could be ascribed to hypercalcemia. So she wanted to feel better, and as a result, she wanted to have an operation. So she was not perfectly healthy. She had a past medical history remarkable for coronary artery disease and atrial fibrillation, for which she was on both a beta blocker and anticoagulation, obviously raising the attendant risk of surgery since she would have to have her anticoagulant held in the perioperative period. There was no family history of any glandular abnormalities, and the only remarkable part of her physical examination was of her atrial fibrillation. So we went ahead and tried to localize this patient with sestamibi and ultrasound. We showed just the sestamibi here, which showed non-localization and just significant uptake in a gland marked by thyroiditis. So we're left at the end of the day with, in this specific patient, do the surgical risks outweigh the benefits, and would this patient indeed feel any better if we performed curative parathyroidectomy? So, by way of background, as everyone in this room knows, there's been a changing epidemiology of primary hyperparathyroidism in the United States, such that today, well in excess of 85 to 90% of patients have what most would define as asymptomatic disease. As a result, I think there's a lot of dissension among practitioners about what the appropriate treatment strategy should be. Should it be surveillance? Should it be medical management with calcimimetic agents or bisphosphonates? Or should parathyroidectomy be attempted? So as a result of this debate, there's been 3 NIH consensus workshops held. The first was in 1990. Subsequent ones were in 2002 and 2008. I don't mean to date myself, but the data I'm going to be showing and the logic behind the performance of the clinical trial predate the most recent workshop in 2008. So when we embarked on this study, the practice guidelines were those from 2002. And at that time, the criteria for surgery in patients with primary hyperparathyroidism would be youth, age less than 50, a significant elevation in serum calcium level, a significant elevation in 24-hour urinary calcium level. Obviously, that has subsequently been expunged as a criterion. Compromised creatinine clearance, osteoporosis, a failure of medical strategies, or symptoms. And when people talk about primary hyperparathyroidism, obviously there are those symptoms which are well-defined, and those were the ones referred to by the NIH workshop, including nephrolithiasis, pancreatitis, peptic ulcer disease, and those that are really poorly defined, but in many parts of the internet, those that receive the most attention. And those include obviously arthralgias, myalgias, and psychiatric and neurocognitive disability, which is what our patients' chief complaint was. So in 2002, the NIH workshop actually weighed in on the data regarding psychiatric and neurocognitive disability and said the following. This is a quote: "The panel considered other possible factors such as neuropsychological dysfunction that could enter into the decision-making process in an asymptomatic patient. Because of continued uncertainty over the specificity of the factors, the panel believes that they should not be regarded as criteria for surgery." So that was the state of the evidence and what guidelines recommended when we saw this patient in our clinic in 2003. So the question is, what is the relationship between calcium and cognition, and does parathyroidectomy indeed have an impact on these symptoms? So whenever I think you start out with a possible research study or a question, you have to do a literature review to see, A, is it an important question, and B, is it a novel question, or have others answered it already? And so we started with a literature review, and what we found, of course, is that there was a paucity of evidence from prospective trials that actually used validated psychometric instruments to answer the question in a robust way. Well, what were the limitations of the data? Well, they were significant. Many of them measured quality of life, which, strictly speaking, often incorporates psychiatric and neurocognitive funding, but which is not disease-specific. Rather, it's a generic measure of disease. Many were based on self-report questionnaires. They'd been either not validated or poorly validated and were centered around homegrown instruments. This was an example of the state of the science. This is a study out of the University of Michigan where they asked patients with primary hyperparathyroidism at baseline and then 2 and 6 months postoperatively, have you felt sad and have you felt depressed? And what you, of course, see is that patients preoperatively with primary hyperparathyroidism in this study appear to have between 25% of them and over a third of them said that they did feel depressed, and these feelings of depression, at least in a self-reported fashion, appear to improve in the postoperative setting. This is another study by Pasika and Parsons out of Calgary in Canada. And here they actually created a disease-specific instrument called the Median Symptom Index Score, or MSIS, which is specific to patients with primary hyperparathyroidism and rather hyperparathyroidism. And they administered this instrument to patients preoperatively and then postoperatively immediately, and then at 3 months and 12 months. And what they, of course, find is that patients with primary hyperparathyroidism, as well as patients with secondary and tertiary hyperparathyroidism, appear to have a reduction in symptoms after surgery. These appear to be durable, and they appear to be more profound than in a control group of patients with thyroid disease. There were 3 problems with this evidence, however. One is this instrument was never validated. Secondly, it was based on self-report. And third is it wasn't specific, actually, to primary hyperparathyroidism. Rather, it was a generic instrument, and patients with secondary and tertiary disease also were included in the study. So we said, based on this review, it's an important question, and no one to date has answered it. So we decided to embark on a clinical trial. Now, clinical trials take a long time and can be very expensive when they're done well. And I think there are a series of steps that you have to think about before embarking on such an endeavor to make sure that you're likely to be successful at the end of the day. So first of all, we have to generate a testable and novel hypothesis. And I think when you do a clinical trial, it's important to make sure that you do a pre-hoc power calculation to assure that you can enroll enough patients to be able to have the statistical power to ultimately answer your question. Secondly, you have to define your study cohort and ensure that your cohort of patients is one for which generalizability is possible. You have to very, I think, explicitly establish eligibility and exclusion criteria. I think more and more in a complex healthcare environment, you have to realize you can't do this kind of study by yourself. And as a surgeon, I'm very well aware of my own shortcomings, and I knew that to do this kind of trial, I would have to assemble a multidisciplinary team of investigators. I think as you go through performing a clinical trial, you have to ensure quality as well as standardization of practice. So when you get started, you have to have what are called SOPs, or standard of practice documents, so that everyone does the same thing for all patients. You have to assure that if patients have complications or adverse events, they're reported in a standardized fashion, typically on CRFs or case report forms. You also have to have a group of objective individuals who are following your clinical trial to assure safety of patients. So you want to appoint a Data Safety Monitoring Board, or DSMB. And as you go through the trial, you need to continually audit your data and even, frankly, perform interim analysis to assure that no one is sustaining injury before getting to your final outcome measures. Statistics and statistical analysis can be complex, and so often it's important to enroll a statistical consultant. And then what Dr. Emerson is going to talk to you about is, in the end, you have to ensure that your data are robust enough to meet the criteria of peer review, whether that be peer review presentation or publication. So let's take that sort of map and apply it to our specific questions. So we formulated 4 questions as we embarked. The first was, what is the prevalence of psychiatric and neurocognitive symptoms and disability in patients with primary hyperparathyroidism? So that's an epidemiologic question. Secondly, does parathyroidectomy even improve these symptoms? Third is, presuming it does, when does improvement occur? And finally, is this a transient improvement, or are the changes afforded durable? So the next thing in our laundry list was to define our study cohort. So because I'm a surgeon, we decided to use a convenient sample, which would be patients with primary hyperparathyroidism referred for parathyroidectomy to our practice, which consists of 4 high-volume endocrine surgeons at a single center over a 5-year period. And then we very carefully set out exclusion criteria to make sure that we had a generalizable group of patients. So for the purposes of consent, we chose adults who spoke English. We excluded patients who had very severe disease such that the severity of their primary hyperparathyroidism might compromise our ability to measure subtle symptoms, so hospitalized patients with hypercalcemic crisis or needing inpatient psychiatric care were excluded, patients with biochemical problems that could cause neurocognitive disability like hyper and hypothyroidism were eliminated, patients who had traumatic brain injury and other forms of cognitive impairment. Patients with a recent cancer diagnosis were excluded because we felt that might lead to feelings of anxiety or depression that could affect our measurement. And finally, patients who did not have sporadic primary hyperparathyroidism, since really that was our question at hand. Next is building a research team. So I'm a big believer whenever embarking on a problem that two minds are always better than one. So we took a team approach, and in addition to having a group of surgeons, we decided to enroll endocrinologists. I was concerned about just having academic referring physicians, and that I suspected these would be tertiary or quaternary complex patients. So we enrolled a group of community endocrinologists to refer patients. We enrolled psychiatrists and neurocognitive specialists from our Child Study Center at Yale, and finally statisticians. And then in terms of the sort of brass tacks of doing a clinical trial, we had a data manager and finally a research associate who facilitated patients taking the prescribed tests. So once we'd done all of that, then you have to develop the protocol that you're going to follow. So you develop a protocol, and then you must assure that it has either institutional review board or human investigation committee approval before embarking on any interventions with patients. A big problem that we anticipated actually was patient recruitment and retention. Why? Because patients with primary hyperparathyroidism are obviously elderly patients, and elderly patients are a very vulnerable population. It's hard to attract them. Why? Because it costs money to pay for parking. Most of these patients are on fixed incomes or rely on dependents or public transportation to take them to and from hospital. And ambulating from a clinic to a testing center is a very big deal and a perceived obstacle to enrollment. So we tried to anticipate that by notifying our referring doctors early so that patients were prepared and could plan for these expectations. We tried to identify a battery of tests that had as short a time as possible that would keep patients in the hospital. And finally, we tried to come up with incentives to get them to participate, either in terms of reimbursement for parking or meals. We also chose our study location very carefully such that it was in close proximity to our clinic and on the first floor of the hospital. And finally, of course, whenever you collect primary data in particular where there are potentially patient identifiers, we had to assure data security and a locked place to keep our data. And then I think as you go forward, it's very important to keep people in a clinical trial engaged in that clinical trial. And that's particularly difficult, I think, if you're doing a multi-institutional trial or a multidisciplinary trial. So what we did was we set up regular research team meetings on a weekly or bi-weekly basis, and we had regular communication to give people feedback about how things were going. And as you move forward, it's important to recognize when you have a problem and at that time modify or revise your protocol in light of either safety-related issues or challenges that you have encountered. And finally, I think whenever you embark on a research study, it is really important to think about resources. And unfortunately, clinical trials that are done prospectively, and particularly those done in a randomized prospective fashion, are extraordinarily expensive to perform. And so if you have a large group of people committing their time and energy, including patients, you want to figure out a way to pay for it. And the way I usually approach this problem is start small. acquire pilot data that will then inform an application for external funding. And when I look at external funding, I usually start small and then work big, usually starting at an institutional or even departmental level, building up potentially to foundations which may have specific interest in the area, professional societies, for instance, the American Thyroid Association, state, and ultimately the gold standard federal and NIH funding. So this is an example of the approach I took to this study. I started small, so I went to the Department of Surgery at Yale and got a $5,000 award. But with that data, it allowed me to apply to the Paget Foundation, where I got $10,000 more dollars. I then went to a nonprofit foundation called the Donahue Foundation that just funds research in Connecticut, had them help. Then I went after career development awards for my professional society, which is academic surgery. I looked at the constellation of patients, said these are geriatric patients, and ultimately went to the Pepper Center at Yale, which is targeting geriatrics, and finally the American Geriatric Society. So start small and work bigger. So we decided before embarking whole hog on this to do a pilot study. So this was the pilot study that we did. It was published in Surgery in 2005. And in this study, we took all patients with primary hyperparathyroidism and with benign euthyroid disease. So this was a case control approach, who were referred to surgery by 3 surgeons at a single institution over basically a 6 to 8 month period. And we evaluated only 2 time points because we wanted this to be quick and dirty to get data, pre-op and then 1 month post-op, and we assured that the protocol was HIC approved. We collected a number of independent variables about our patients, which included demographic and clinical characteristics, biochemical markers, and finally mode of anesthesia, which obviously could affect, at least in the short term, psychiatric and neurocognitive function. And then we identified a battery of tests of psychiatric and neurocognitive outcomes, but this time we chose to choose 4 tests that had been validated. So, to highlight 3 of them. So this time we're not using self-report, we're not using unvalidated studies. And here we relied on the expertise of our colleagues in psychiatry. So we used the Groton-Mays learning test, which is validated and used specifically in elderly patients. We used the Beck depression inventory. Again, this is not only a validated inventory, but a reliable test. And finally, the Spielberger Statetrait anxiety. Basically, this is a 2-part test that measures both transient and stable anxiety symptoms over time. And again, it is validated. So here were just a quick overview of the demographic and clinical characteristics of our patients with primary hyperparathyroidism and benign euthyroid disease. And even though the number of patients is very small, it was a total of 55 patients, they were very comparable overall in their characteristics, with the exception of the fact that patients with primary hyperparathyroidism had a higher SEERS score, which is a cumulative illness related score, a measure of complexity and comorbidity of disease. Not surprisingly, when we looked at their serum biochemical testing, we saw that preoperatively patients had elevated intact PTH and serum calcium levels, and postoperatively in the parathyroid group, those regressed to normal. This was not seen among our thyroidectomy patients, and TSH levels were consistent pre- and postoperatively, so not a confounding variable. And these are our summary results. And basically what you see, thyroidectomy patients are compared to parathyroidectomy patients, and preoperatively the parathyroidectomy patients on the Beck depression inventory had statistically significantly more reported depression as compared to their thyroidectomy colleagues. And postoperatively, that difference between primary hyperparathyroidism and benign euthyroid disease, the difference disappears and the 2 sets of scores become comparable. And these are just some graphic representations of testing from the Groton-Maze learning test. You see on the left preoperative testing, on the right postoperative testing. And on the left, preoperatively, there's a little bit of separation between the curves for the thyroid and parathyroid patients, while that difference appears to resolve somewhat in the postoperative setting. And similarly, there's a gap between lines preoperatively and overlap postoperatively. So we used these data, which really just suggest perhaps there's a signal, certainly nothing robust, but maybe there's a signal that merits further interrogation. And so with that, we embarked on a much larger study that ultimately was published in 2010 in the Annals of Surgery. So here we sort of changed our research question and learned from our experience and became more granular. And we asked 3 questions. Again, we wanted to know what is the prevalence of the psychiatric and neurocognitive symptoms of primary hyperparathyroidism, and 2, does parathyroidectomy improve these symptoms? But our third question now is, are there biochemical predictors of improvement? And whenever you have a research question, your grant application must include your own hypothesis. And this was our hypothesis on starting out. It is change in PTH level that predicts a change in state anxiety, which in turn predicts a change in memory. So this is what we came up with as our hypothesis. So this time we embarked on a study that went for 5 years as opposed to 8 months, and we had more data collection points. We still studied patients preoperatively, but now we went out at 1, 3, and 6 months postoperatively, and obviously selected 6 months because that is the definition of cure from parathyroidectomy, a normal serum calcium level 6 months after the time of parathyroidectomy. We also ramped up our statistical analysis, performing Pearson correlations, but also this time path analysis to try to test our causative hypothesis or algorithm that it was PTH going to anxiety, going to spatial memory. So this is the start of our results, and I really show these for the purposes of full disclosure. And this is an area where we clearly could have done better in our clinical trial, and I've learned a lot from my mistakes over time. So we enrolled 212 patients in our study, but we had a significant dropout rate. At 1 month, we had 159 patients still enrolled. By 3 months, we only had 117 patients enrolled, and by 6 months, that number was down to 102. So about a 50% dropout rate. In retrospect, why did people drop out? Well, these are the realities of doing clinical research. You cannot control the situation all the time, even when you think you've anticipated all the barriers. Specifically, what patients and their families told us is that economic hardship and inability to travel were the reasons why they dropped out. Patients just are not motivated to come back 3 months and 6 months after surgery, especially when they appear to be cured by the operation. And these were our results. So these are our patients with primary hyperparathyroidism who underwent parathyroidectomy. And you see that overall it appears to be a pretty generalizable group of patients fitting the typical demographic profile, that is mature, white women with primary hyperparathyroidism who in our practice typically underwent minimally invasive parathyroidectomy, which I think benefited the study in that the effects of general anesthesia, obviously it can affect psychiatric and neurocognitive function, were kept to a minimum. And it was interesting to see that based on self-report, about 50% of patients said that they were tired, and about a quarter of patients said they were either anxious or depressed. This shows graphically results of our biochemical markers, and you see, of course, that the biggest change was PTH in terms of reduction, followed by calcium, and obviously TSH levels did not change during parathyroidectomy. And this is a matrix of results, and really we don't need to get into results at the granular level. I think the important thing to see is that everything with an asterisk is demonstrating a statistically significant improvement or change. And you see that preoperatively, patients all the way on the left had mild depression based on multiple validated measures of depression, and they had clinically significant anxiety as compared to the normative U.S. population, and that all scores statistically significantly improved, and that change was durable at 6 months. So this is not a placebo effect. These are durable changes. And again, this demonstrates the temporal trend in that very quickly patients experience improvement in symptoms with a giant jump at the first postoperative visit, but that the improvement continues at a more gradual slope all the way out to 6 months, and it's robust across all studies employed. And then this is a path analysis, and this is testing of our hypothesis. And what you see is that delta PTH, reduction in PTH, and the scale of that was directly correlated with the state anxiety of patients, and that in turn, the state anxiety of patients was significantly correlated both with depression based on BDI score, psychiatric distress based on the BSI study, and legal errors on the Groton-Mays learning test. And then when you take the Groton-Mays learning test, the legal errors from the prior path analysis are in turn directly and significantly correlated with executive errors. And so with this, we were able to conclude 4 things. 1, depression and anxiety appear to be common and significant symptoms among patients with primary hyperpara. 2nd, that spatial working memory is impaired in primary hyperparathyroidism. 3rd, the parathyroidectomy seems to be associated with significant improvement in anxiety, depression, and spatial working memory. And 4, it appears to be PTH, not calcium, that is associated with these findings. I think whenever you're going to think about publishing something in peer review, not only should you describe the strengths of your study, but obviously fully reveal the limitations of your study. And ours definitely were limited by a loss to follow-up, and also by the fact that it is a restricted population based on demographics confined to elderly white women. I would argue those are the demographics of the disease, but certainly the NIH, looking at enrollment of minority populations, would be concerned about the fact that we had very few African Americans and Hispanic women. And finally, in spite of the fact that we enrolled community endocrinologists as referring doctors, we have to worry that there was a referral bias in that we were in a surgical clinic at an academic medical center. But ultimately, we concluded that neurocognitive symptoms should be evaluated routinely, and that the presence of depression or cognitive dysfunction should potentially be considered as criteria, at least for referral to a surgeon and possible performance of a parathyroidectomy, which is not to say patients should undergo parathyroidectomy, but they should have the opportunity to have a discussion. So does it make a difference? Do we make a difference as clinicians, scientists? Well, I would argue, I think we maybe had a little bit of an impact in that this is the 2008 Third International Workshop on Primary Hyperparathyroidism. So I showed you the quote from 2002's workshop. This is the 2008 workshop. And in part based on some of the data our research group compiled, as well as other excellent data from around the world, they wrote that patients who have overt signs and symptoms of primary hyperpara are symptomatic and in almost all cases benefit from parathyroidectomy. But patients who appear to have asymptomatic primary hyperparathyroidism frequently have significant neurocognitive compromise that is only appreciated after a successful parathyroidectomy has unmasked their symptoms. So incremental change, but potentially the result of a small idea, at least it started small, that grew into a much bigger clinical trial. So as many of you in the audience know, the rhinoceros is the official animal of parathyroid disease and of endocrine surgeons. And this is a baby rhino born 6 months ago in the Los Angeles Zoo. And I always think it is important as a clinician scientist to recognize all the participants in your clinical and research team. And these were the other members that helped to make this trial a relative success. Thank you. So what questions do y'all have? Yeah, so that is an excellent question. The question, just so everyone in the audience can hear, is how difficult is it to really balance life as an active clinician and as a scientist, specifically if you are a clinician who does clinical trial research. And I think, I'm not sure I have the perfect answer to that. I think it is something I've learned by trial and error. Clinical trials, I will say, are among the most, if they're done well, which usually means running a multidisciplinary trial or quite frankly a multi-institutional trial in order to get sufficient and diverse enough patient populations, takes an extraordinary amount of time. It also takes, I think, a fund of knowledge that I actually didn't come to it with, and I sort of acquired on the job, and I think that is probably, looking in the mirror, made it harder for me than if, when I was a fellow sitting in your seat or a resident, I had actually been mature enough to say, this is something I think I may want to do one day. I want to learn how to do a clinical trial by either shadowing a clinical trialist or reading about it. So I think it's been kind of hard. I think what you need to do, though, is first of all, if you think this is something that you want to do, to identify that early and to start acquiring the skill set and fund of knowledge to know how to do it. Secondly, I think it requires having a personality where you get along with people and can lead a diverse group of people. And third is find a way to protect your time. Now, you know, probably the easiest way to start is when you start as, say, a sub-investigator or a co-investigator, to assure that built into the budget, and again, I hate to keep coming back to resources and money, but this is important, is to assure that you have some proportion of your time and salary that is reimbursed for in that trial. Now, that may be a very small amount, 1% or 2%, but as you become more experienced and you rise to a leadership position, then you will ask for more of your time to be reimbursed, such that, you know, principal investigators for international trials may have anywhere from 10% of their time, if they're a single institution PI, all the way to, say, 30 to 50% of their time reimbursed. And I think in the environment that is academic medicine, that's an important thing to do, and that is pay for your time in order to protect your time, because clinical trials take a lot of time to do well. Yeah, so that's a very good question. So the question is how do you address or how do you think about conflict of interest if you are, say, a principal investigator in trial and at the same time you are enrolling patients in your own practice? And, you know, this is a study in benign parathyroid disease, but I'm a surgical oncologist, and most of the trials that I do are in the management of locally advanced and metastatic thyroid cancer. And quite frankly, I got into it because a lot of patients who I operate on either are not cured or move into a category where they need to be enrolled in clinical trials. In that setting, I think I feel less conflicted than I did in perhaps this study, where I'm a surgeon, I probably should be motivated to operate and therefore enroll patients. I think I found this niche as a surgeon doing clinical trials using small molecule therapies, in that I'm in a position where I can't really help these patients surgically, and therefore I'm really just looking for alternatives for them. What I always say to patients, though, is before you enroll in one of the clinical trials that I can say offer you at my institution, I actually insist at the very least they go to clinicaltrials.gov, meaning the NIH website, to look at alternative clinical trials available in the United States or in the world. And secondly, I always offer to my patients to make phone calls for them. So before you commit to this option, if you feel there is potentially an alternative option at another institution or in another city, tell me, and I'm willing to send an email, make a phone call to a colleague to say, have a discussion so that you're informed. So I guess that's the way I would answer your question. Do I think it is perfect? I'm not sure it is. It's probably imperfect, but that's how I sort of have resolved it in my mind. Okay, and the last thing I would just say is, I think that every day in your practice you will see patients for whom you're not sure what to do. And when you're in that situation, I think you have potentially identified a research question. And instead of moving on to see your next patient, potentially pursue these opportunities, because this is just one example of many where it's not my career, but it certainly has been an important part of my career. Thank you very much.
Okay, well, that was a very nice talk, and I think it's always good to have more than one speaker because technically our charges are a little different, but in fact, I'm sure we overlap. But I think we're also, you're going to get different pictures, different sort of views of the rhinoceros in our talk, although some of them will be similar. So if I can have the first slide, please. So just to clarify a little bit here, the thyroid meetings actually see the transition of the presidents, treasurers, etc. But the way the journal works is I hang on until the end of this year as the editor, and then next year Dr. Peter Kopp will be taking over. However, he is to transition. He's been seeing all the new papers since August 1st, and I am finishing up with some of the old papers, and I know we have at least one person in our audience who has a paper out for revision now. So this process of publishing is actually a very long-term process. I'm going to approach this from the point of view. I think one thing is clear from both of our talks is that as fellows, you would like to publish. Ideally, you would like to have papers in press by the time you finish your fellowship. And I think it's good to have that as a goal, but also to think about research and writing papers as part of, in a way, something that you want to be thinking about doing throughout your career. And it's also something that you can acquire the skill to do. Some people think that it's beyond them to be an author. But I think in the medical field, there is so many observations to make and so much knowledge to be contributed that every physician should think about authoring a paper or being a co-author in a paper during their career. Also, time is something that can always be an excuse, but it's a matter of pacing yourself. And then I think what good does it do for me? I want to emphasize that by participating in writing a paper, it makes you a better clinician. And by that I mean it's very easy to look at diagrams, and in fact, to put in the surgical context, as you know, you can look through a book and you can see the diagrams of the muscles, and that doesn't mean, however, that you can operate. In the OR, the actual specimen, the actual operative field that you see is totally different from what the medical illustrator has shown you. And that's also true when you write a paper. You realize that one case that you saw, that you have to take the information from that case as a grain of salt, because by writing a paper, you see a whole spectrum there, and you realize that you become more mature in your thinking and not so artificial. I'd like to encourage you then, if you decided that you want to be a co-author or an author, to put your ideas in writing. So you alluded to this. You said that Dr. Sosa said that, you see patients and you need to pursue some of this. I think that what you want to do actually is really put some of this in writing. Nowadays we have the advantage that we can start a file, start a folder actually, and start a text file of your ideas. You come up with an idea, it's pretty vague, write it out, start writing it out. This is for yourself. And how many of you have EndNote? Okay, great. Because what you can start doing is you can make some statements, and you can start checking this against the literature, and you can add your references, and you can modify this. So you need to, you're really in the process of forming your idea, and it may be an idea that you act on a year from when you started, or 3 months, or even later in your career when you're out in practice. I want to now turn, this section of my talk actually I put this in because people, when I gave this talk before, they really wanted to know how to get started in research. And I think you've really covered, Dr. Sosa's really covered all of the preliminary things that you might want to do. But of course, in a basic science type of paper, it's going to be, there are going to be different questions. But I think throughout this, there's going to be certain themes. Let's just quickly turn to the types of papers that appear in peer-reviewed medical literature. You have editorials and commentary, and the difference really is that an editorial tends to be written about an article that is in the that's being published in the journal. I might just say that you, as a fellow, you might make your mentor aware of your interest in areas, because often, or occasionally at least, fellows are asked to write editorials along with their mentor. So the mentor is asked to write an editorial on something, but oftentimes the mentor will recruit a fellow, and this can be a great experience. It also can work as a junior faculty member. Statements, really, I put that in there to make the distinction between when you read something, you want to know, is this done by an organization, is a statement by the organization, or is this something that comes from authors? Most papers in the peer-reviewed literature are coming from authors. That means that authors are responsible for their content. It's very easy if a paper is not good, or if it is good, you can always ascribe blame or praise to the author, but you can't do it very well with an institution. And that's why I think that in terms of sort of value, the value of peer-reviewed literature is that it comes by and large from authors. The other things here, I think this is pretty obvious. I want to emphasize that even though the original study is sort of considered the top of the food chain in terms of prestige for a medical journal, that you should not be too dismayed to write something that may not be an original study. It's an important part of your training, and it's an important contribution, because you may write a letter to the editor, for example, or a case report, which then forms the seed for what you later develop as a study or as a hypothesis to act on. So let's assume now you have the material ready to write up. And there's of course a big gap between actually when you first had that idea and you're at that stage. You're now ready to put write this up. So what I'm going to do here is talk about the elements of the article, starting with the title, which is basically that it's you want a title that's not terribly long or not terribly short. If it's too long, people will have trouble remembering it. Try to include as much specific information in your title as possible. And the reason for that is that titles, your article will become more prominent in the literature because people will be able to find it easier. And it helps people that are looking for specific information to have a title that gives that specific information. I also avoid abbreviations. Now, what is not on this list, in fact, is I'm absolutely amazed at how many authors will not put the message in the title. They will put sort of, serum T3 levels in hyperthyroidism as a title, but that does not really give you a message. And what you're looking for is a message that will tell the readers what the novel information is in your paper. What's the message that makes this worth a publication? It will also help the impact factor. And I have recommended to a number of authors, in the past few years, changes in their title because I want the impact factor to be higher also. That just also, gives me the opportunity to say that really the editor and the authors want the same thing. We want the best papers. Sometimes I think you may feel that when you submit a paper, it's like a trial. And can the paper pass the trial, guilty or innocent? That's a bad analogy because we want the best paper. The other reason it's a bad analogy, by the way, is your paper may not be accepted, but it's not necessarily guilty. It simply doesn't fit the journal at the time. So that there is worthy material that doesn't always get published in a particular journal. And the other thing is that the editorial process, the review process, is not perfect. Also, it's important here, I just want to emphasize, might seem obvious that you want to list the authors. List your full name better than listing initials. Put in a middle initial, and the reason why you want that is that it's important that readers can identify you. Because I noticed that Peter Snyder is one of your co-authors. There's also a Peter Snyder at the University of Pennsylvania who does reproductive endocrinology. And, as you read the literature, you want to be able to distinguish between these people. And also give the country that the paper comes from. The abstract is absolutely key because, as you know, this is available to everybody, whether or not they subscribe to the article, to the journal. And the abstract, even people who subscribe to the journal, oftentimes the only thing they read is the abstract. They may not have time to read any more than the abstract, but the abstract will be something that will attract them or sort of keep them away from reading the main article, depending on how interesting it is. The format that Thyroid uses is the background, methods, results, and conclusions. And I always emphasize that it is important to state the hypothesis that the study tests and state give one or two sentences that allows the reader to understand how you came to this hypothesis and why it's important. Keep your results as results and your conclusions as conclusions. Don't put conclusions in the results. The results should provide as much detail as possible, as much specific information, rather than saying that serum TSH concentrations were elevated, give the actual data. Ideally, you could give almost all of the most important data in the abstract. So conclusions really sort of give you the significance of what the observations are. They challenge the reader and almost, you know, this is what you conclude from the study, and you can also speculate a little bit in your conclusion. Methods are key. You need to give the type of study it is, retrospective, prospective. You need to give some of the key exclusion criteria or inclusion criteria, the key elements of the methods for if you do laboratory studies, what the methodology is. I think most journals probably do, to have an introduction that is short and to the point. The background is needed. The point of the introduction is that in the introduction, you are going to state the hypothesis right at the end, or the objective, but by the time the reader comes to that, the reader should understand why you came up with this hypothesis. But do not make a long introduction, because the reviewers are reading this and they're saying, get to the point. I mean, their time is limited. I'll say more about that later. It's important that you define terms precisely in the methods. If you're using a term, for example, chronic thyroiditis, some terms actually mean different things, and so it's going to be important that you try and be as specific. The terminology is as good as possible, but if there's some question about this, you also define the criteria for that term. You define groups precisely. One point that I think, this is sort of my bias, but I like to come up, if I'm going to have groups, I like some names to the group which tell the reader what the group is, rather than using group A, B, C, and D. Because as you read through this, again, serum T3 concentrations were lower in group B than they were in group C, and you now got to go back to and ask yourself which was group B and which was group C. So you can come up with the short abbreviations, or even not so short. We did a paper that was on where we have models of maternal hypothyroidism, fetal hypothyroidism, normal, and combined maternal fetal hypothyroidism. And I think we used M hypo and rather than group 1, 2, 3, and 4. It was just easier for the reader to follow. You want to include a good section on statistics and criteria for testing the hypothesis. You want to give information on study oversight and informed consent, and if it's an animal study, then you give information about use of animals and the institutional approval for that. In some journals, you'll see that they've given a lot of methodology in the figure legends. Now, I think that's appropriate for certain journals, but by and large, in most medical journals, put the methods in the methods section. There is some detail that you can give in figure legends, But in general, I put the methods in the methods section. The results section, you state the results specifically, and you always you refer to your results. If you have a table, you refer to the table, but you don't simply say the serum T3 concentrations are shown in tables 3. That's very frustrating. The reader wants to know what you found. So you say serum T3 concentrations were elevated in the MT hypo group compared to, and that's another thing that's important, is you want to know, you can't simply say that they were elevated in the group without comparing. What are you comparing to this to? And then put in parentheses table 1, table 2. We get frequently papers where tables and figures are put in and there's absolutely no reference in the text to them. And those that always is something that they need to do. Again, just as in the abstract, try to limit interpreting the results in the results section. Some people like to make the results section an argument for their hypothesis. So they interpret them. I think most journals prefer that you give the data and then in the results and you interpret the data in the discussion section. Also, there is actually one little peeve I have, and that is that it'll be stated that we showed that something occurs. And I generally don't like the idea of showed as a statement. And I know that those of you who have sat in through some of our presentations, that is done. But what if it's done a lot in a paper, it suggests that you already have a bias and you're trying to prove something. And actually what you're trying to prove the null hypothesis. So you want to report that we observed that, or these levels were higher. That is, I think, preferable. And also, it's not clear that if you say we showed something, the implication a little bit is that we could show this, but maybe somebody else can't show this. So you want to report your findings. Just a word about tables and figures. Tables can show exact results, and that may be important because many people would like to read, when they read a paper, they want to give their own, they want to interpret the data themselves and not simply rely on the authors. And so they can't do that with figures. But if you have data, you can actually go through that data and you could come up with your own interpretation, in a quantitative way. Figures are memorable in that you can show the figure and it's good for slide presentations. So I think you need both. It's important that you follow the journal instructions for figures and illustrations. It's amazing how many figures are submitted to the journal that are not of good quality. And one of the problems with this is that it delays publication because the figure has to be sent back for a better figure. Also, sometimes we like to use the figure or the image on the cover of the journal, and we can't use it because the quality is not sufficient. If you do box diagrams, I think there is software that allows you to do some nice diagrams. And some of the box diagrams and flow diagrams that that I see submitted are not of great quality. And frankly, I don't necessarily reject a paper or hold up a paper for that reason, because you get very busy. But when this paper is published, it's not going to make as good an impression as a nice flow diagram that's somewhat balanced and the box sizes are the same and all. And you can get that with current software. The instructions to the authors will tell you about what the criteria are for the quality. Just in terms of what you're going to submit, you're going to submit a main text file, and then you're going to submit imaging files. And that's about it. You may submit a video file. So you can get all of your material in just one main text file and then the image files. In the results, you want to state what the figure or illustration shows. And I've already talked a little bit about this, so I'll just... the discussion, what is important to briefly summarize your results, to provide an interpretation of the results, and to clearly sort of separate this. You want to then let the reader know how the results support or refute the hypothesis. You want to indicate how the results add to or support or do not support concepts in the literature. And I think in general, you want to keep some kind of order for this. You don't want to go back and forth unless your paper has two clearly different components. And then it's very important for you to specifically state, in your summary, what the novel results of the study are. Some people hesitate to do that because that will allow the reviewers to attack a possible weak point. In other words, if you don't say that, it's a little harder to it's easier to either look in the literature and say, okay, this has been proven or not proven. But I think you have to do it. Then Dr. Sosa talked about the limitations of the study. I think when you talk about the study biases, it would be a good idea to indicate what the biases, what actually is the bias. For example, referral bias. The referral bias in the study presented could be that the patients who are referred for surgery are actually more symptomatic in amongst all patients with primary hyperparathyroidism. The patients that are referred for surgery are more symptomatic. And so but specify that in your discussion. And then you have a sort of a wind-up of summary and conclusions. References, they need to be checked carefully. Also, if you have your references formatted correctly, that tells the reviewers and the editor that you have made an effort to follow the instructions, author information. It's very frustrating particularly in journals that don't have a lot of resources, to send the paper back because the references aren't formatted correctly. It says that you haven't read the author information. It also sort of suggests that maybe you submitted this paper to another journal and now you've submitted it without changing the references to that journal. I know we had a situation where a paper was literally we found out it was rejected the day it was submitted. Or should I say, did I have that right? It was rejected and then submitted the same day. And so it may bias the review. It's important that your review of the literature not be just current, but look for some of the older references. Also try and unless it's a letter to the editor where you don't have a lot of references, try to cite primary sources, at least to a certain degree, because particularly when it's a critical statement, if you cite a review, and it's really critical, it may turn out that the review really has made a statement, but there's no support for it. And then occasionally we get papers, citations that have nothing to do with the statement at all. So that's not good. You want to acknowledge grant support, the help provided by colleagues, disclose ties with industry, etc. So now I'm going to just turn quickly to some elements. You want to avoid redundancy. It's better to say something, not have long, flowery sentences, which simply, again, are frustrating for reviewers and make the paper longer. See if you can say that whatever you write in a shorter sentence. Sometimes papers are written where the same thing is repeated in 3 different sections. So you have to not be too redundant. At the same time, it's interesting that the papers that have a lot of redundancies in them also have a lot of information that is omitted. So at the same time, when you're trying to shorten things, shortening things does not mean leaving out critical information. They're 2 different things. A lot of people will say, well, I can't possibly reduce the length of the discussion or something like that. I need all this room to write. And it's surprising, actually, that you can, by some wordsmithing, you can craft it to be shorter. Incidentally, as an editor, when I get the recommendation from a reviewer that the discussion needs to be trimmed by a third, I basically ignore that, because that doesn't give the author any idea about what to do. To me, if they need 3 pages to make the point, they should have it. But most of the time, what the reviewer is really saying is there's a lot of repetition in here. There's a lot of material that has nothing to do with the main point of the article. So that's what you want to look. Don't take the recommendation literally that all you want to do is figure out how to reduce the discussion by a third. You think about what the discussion has said. I've already talked about defining terms. That's enough. Avoid duplicate terminology. There are papers where the 2 words are used for the same, or 2 phrases for the same disease, and it can be very confusing, where it appears that you've actually got more than one group, where you've got one group, but you're using 2 words for it. You want to avoid circular logic in your discussion. You're starting out with a hypothesis. You're not starting out with a proven thing, which you then prove all over again. Spell check. Look at words that are flagged. Be careful. This is a bit of a problem. Sometimes, if you have the autocorrection turned on, it will change the word, or it will put in a word that has a different meaning. This is very important. this is when, before you actually submit the paper, and this actually goes back to when you're formulating your study. So you're in the process, but let's say you're all ready to submit your paper, but you're getting very close. You have to recognize the importance of both expert review and non-expert review. And by that I mean you want an expert to review your paper to make sure that the science is good. But you also want a non-expert in the field to review your paper to pick up areas where the reader just the flow is not good, and also the non-expert will pick up jargon that should not be used because it's just not clear. Also, experts tend to fill in the blanks when they read a paper. They already know the technology very well. Non-experts want the logic to show, and so I can't overemphasize the importance of doing this. It's all right to suggest to reviewers. I suggest that you, if you're submitting to a journal where this might not be the main part of the journal, it might be a little peripheral to the journal, suggest reviewers, because the editor does sometimes it's a little difficult to know who the experts in the field are. And we can tell if the review is bad. So if you suggest your friend to write the review, first of all, we'll be able to find out that your friend has no academic affiliation or any training, and we can tell from the review I'm not saying the wool can't be pulled over our eyes. It can, but by and large, you can tell when a review is good and when it's not, and you can always check it out. So when you get your decision, this should be decision. Actually, it is review. Typically your paper is not going to be accepted on the first go around, so you get the paper back, and here's this long list of comments, and your first, before you even read them, you're depressed. The thing to remember is the list doesn't necessarily mean that the sort of favorability rating of the paper is not necessarily related to the shortness of the list. Sometimes you can have a big list, but these are all things you can deal with. So take a deep breath, hold on to your ego. None of this is meant to be personal. It's simply a critique of what's written. You don't want to delay revising your paper, but don't sit down and immediately make a revision without giving it a little time for thought. Now, that depends on the paper. It depends on your experience. Some people who are very, expert, have published a lot, can turn these papers around fast. But you don't want to go so fast that you haven't really fixed it. Remember that, again, the decision is not personal. If it, and this is something you can discuss with your mentor, if it looks like this is just not the right paper for the journal, move on to another journal. Or it may be that these points are all legitimate and you really have to fix the paper. If you submit a revision, you thank the persons who reviewed the paper. They are doing this for nothing. So they're giving you their time. And many people, in fact, will not give this time. So recognize the people that do actually are doing this because they feel it's important that the medical literature be peer-reviewed. One other thing is when you respond to the things in the revision, don't simply say, well, we already discussed this, or this is, we fixed this. Indicate exactly what you did to the revision. We're not interested in a information regarding these points. We want to know how the paper has been changed. What are the changes in the paper? Now, we can do a comparison, but that's not, we're not coming to grips. We're not really working with the author if we don't have this information. So I think I'll stop there, and there's probably been a lot of gaps, but I'm open to any questions, comments, whatever you have on this. How many people in the room have submitted papers? Okay, so you're all familiar with this. How much of what I've said rings true? Anything that doesn't, or anything that really bothered you about a process that you'd like to share? Yeah, I'm just saying if you can put some quantitative data, that's good. Instead of saying, put the numbers of patients, it doesn't take that much, actually put. And again, read it through and see if you can say it in half the number of words, and then that gives you more space to put in that information. I mean, ideally, somebody could read it and get everything in the abstract. Yes? Yes, in the back.
Thank you. One question. The decision from the reviewer sometimes cannot be, or can be not clear. For example, they would suggest do this and do that, and say we cannot recommend publish in this current format.
Right.
So
okay, I think I'm glad that's a very good question. It's important. It allows me to make a point, which is really a point that is important to make. The decision to accept or not to accept is not the decision of the reviewers. The reviewers make comments in addition to the comments for the authors. They make comments, confidential comments, to the editor. And that's just standard. You can argue whether that's transparent or not. It puts the editor in a spot if there are only confidential comments and nothing much is given for the author. I actually edit out comments to the authors that say whether or not the paper should be accepted. The reason for accepting or rejecting a paper, the review is part of it, but it's not the only part of it. It may have to do with priority. If there are other papers in the field, it may have to do with space availability. The journals cannot accept every worthy paper. And it may also have to do with the fact that there's already a couple papers in press in the journal that so that it sort of drops, makes it less. It's not as timely, the information. So be aware of that. It is difficult. You try and address this. The comments as best you can. As an editor, I try and have a comment occasionally about what I think is the most important part. And I'll occasionally even say I don't think that point of the reviewer is important, but or is something that you need to address. But this is not the rule. By and large, most journals won't do that. Sure.
Another question is about case report.
Right.
What's your view? For example, rare, cases. For example, if you have already published one or two in the previous publication or years, and then you found another one, But it can be written differently as a, like a reference or sequence or something like that. Are you in favor of following up, or you?
Yeah, I think here's where it's important that I should remove my name as editor-in-chief from the slide, because every editor is different on this point. And I know Dr. Kopp actually maybe has a slightly different view than I do, but what I look for is novel insights from a case report. I don't look for, this is the 20th case of this, or even the second, third. I mean, that's sort of in general, but this is something that is somewhat evolving. Now, what we've done with thyroid is we've a lot of patient reports, we've asked that we've put these as letters to the editor. Now, this is where it puts you guys on the spot, because letters to the editor, if you're from certain institutions, it, quote, counts less. But this is actually coming back to what I said when I first started, is don't sit there and plot your career and how you're going to get, so many points. If you have a good case and you think it has a good message, and find a place to publish it. And don't worry whether or not some committee is going to not count it, because I can tell you that if, this is going to impress some people, it's going to certainly be helpful for you, and you can't be too calculating in these matters. I think I had a very nicely written report, but unfortunately we had a couple others, and I offered the author the chance to write a letter to the editor, and the author went to her advisor and was told that, well, it's not going to help you that much, and they didn't come back with a revision. And I thought that was unfortunate, because I thought it would be, it would have been good if that had been published.
All right. Thank you very much to both of our speakers this afternoon, Dr. Emerson and Dr. Sosa. So this concludes the Fellows Track sessions. I thank you guys for attending. I hope you found them educational and rewarding. You will get a survey at some point after the meeting to rate the sessions to help us for future preparations. And before I close, I'll pass it over to my co-chair for maybe a last-minute goodbye.
Okay. All right, yeah. Thank you again for everyone. I hope you guys enjoyed it. Let us know if you see us, what was good, what could be better, or some other ideas that you may have. And otherwise, enjoy the rest of the meeting and some of Quebec. Thanks.